Hello, my name is Anna, and I'm a trainee nurse practitioner working within a nurse-led abortion service. I'm currently studying at Level 7 to gain competency in early pregnancy ultrasound scanning. In this presentation, I will talk about the capabilities and limitations of a nurse practitioner within the abortion service and the impact of COVID-19 and telemedicine. With the introduction of nurse education programs, the contemporary role of a nurse looks very different compared to those of the past. Registered nurses are increasingly extending and expanding their scope of practice beyond initial registration to take on more senior and advanced roles. This is characterised by working at a higher autonomous level that utilises enhanced skills and competencies and often deals with more complex patients or cases. They are educated at Level 7 and have been assessed as competent in practice using their expert clinical knowledge and skills. Other key parts of senior and advanced nursing are clinical leadership, mentoring, and teaching. There are many different titles that comprise senior and advanced clinical practice, as seen on the current screen. There is a recognised need for nursing to be dynamic and respond to the changing needs of the population. Nurses have developed new roles and have been influential in developing new services to meet the needs in a variety of healthcare settings. The Abortion Act came to fruition in 1967. This allowed for the provision of a safe and legal abortion service within England. There were conditions to the Act, such as seen on the current slide. Prior to this, the maternal death rate due to illegal abortions was very high. Nurses have always been involved in the care of women accessing abortions. However, the overall legal authorisation and responsibility has always fallen to a registered medical practitioner. There have been advancements in abortion methods, particularly medical abortions, which have led to new extended roles within nursing that can offer the patient a more holistic provision of care. Although still under the supervision of a registered medical practitioner, nurses can plan, lead and manage a significant proportion of care for women undergoing an abortion. The role of the abortion nurse was developed in response to several internal and external drivers. This includes reorganisation of the NHS and changes in commissioning, as well as developments in the role of health professionals within the NHS, and has provided a backdrop for professional and service development. However, due to the legalities of the Abortion Act 1967, nurses may still not authorise abortions. This means there is still a requirement of 2 doctors' signatures to continue with the procedure and therefore limits the extent of nursing activity within abortion services. As a trainee nurse practitioner within abortion services, I have the appropriate education and training and have passed competencies to perform some advanced roles as specified in the Royal College of Nursing Termination of Pregnancy Framework. My current competencies can be seen on the screen currently. In my new role as a nurse practitioner, my future competencies can be seen on screen currently. There are nurses that have taken on an even more advanced role within the abortion service that I work in. These nurses have undertaken further training to be able to be non-medical prescribers, completed the family planning course, and performed procedures such as manual vacuum aspiration, or MVA, of the uterus for the purpose of miscarriage or retained products of conception. When taking into consideration the advanced training capabilities of the nursing team, we can see that they are more than qualified to be able to plan, develop, deliver and evaluate abortion care within their range of practice. However, the limitations of the Abortion Act do not allow them to authorise, prescribe medications or perform MVA for the purpose of abortion. Most of the abortion service is run by the nursing team, with doctors usually not meeting or assessing the women they authorise and prescribe medications for. However, until there is a reform in law, this cannot change. Abortion care is a widely accessed service within the UK, with 1 in 3 women having an abortion by the age of 45. Despite the presence of an abortion service within the UK, many women experience logistical and personal barriers to accessing care, such as long waiting times, travel distance, childcare commitments, and perceived or experienced stigma. NICE National Guidance 2019 highlighted improving access to abortion care as a key priority. Studies have shown that restricting access to abortion does not decrease the incidence of abortions, but drives women to seek out unsafe procedures that dramatically increase mortality rates. Telemedicine, which is the use of information and communication technologies, can improve access to care and has been utilised in many areas of the NHS. It has also been found to decrease costs and improve safety. Telemedicine within abortion care is an established service delivery model and is recommended in the 2019 NICE guidance to improve access to services. However, prior to the COVID-19 pandemic, was not utilised nationally. In response to the COVID-19 pandemic, policymakers and clinicians had to quickly change guidelines to ensure the continued safe delivery of abortion care. New guidance was published by the Royal College of Gynaecologists in March 2020, which profoundly changed the way in which early medical abortion, or EMA, care was delivered in the UK. EMA is the use of two drugs, mifepristone and misoprostol, taken 24 to 48 hours apart to procure abortion. The effect of the drug is an induced miscarriage and expulsion of the products of conception. The safety, effectiveness and acceptability of the procedure are well established and recommended by the World Health Organization. Temporary approval of legislation was given so that women's homes have been approved as a class of place for both stages of early medical abortion up to 10 weeks of pregnancy. Previously, the women would have had an in-person assessment and ultrasound scan. Mifepristone would also have been taken in a verified clinic or hospital under the supervision of a healthcare professional. Under this new guidance, the initial assessments were to be held over the phone or video call, with an ultrasound scan only being performed if clinically indicated. Medications were either sent by mail or picked up by the patient from the clinic or hospital. This allowed for a fully remote abortion service, reducing barriers that have previously blocked access to care to some patients. This new service was named a no-test EMA. Initially, there were concerns and objections from medical professionals and non-medical persons over this change in practice. Pro-life groups argued that the government went beyond its powers available under the 1967 Abortion Act and that the safety of patients was compromised. There were also some concerns from medical professionals of the safety and efficacy of treatment at home. There were worries of missed ectopic pregnancies, later than reported gestation, hemorrhaging at home, patients being unable to adequately administer medications themselves, and increased incidence of retained products of conception or complications. There were also concerns over practical elements, such as access to technology or poor computer literacy. Patients with poor hearing and vision could also suffer with remote service, and assessing a patient's capacity to consent was also a concern. However, studies have shown a very different picture. A study by Aiken et al., published in February 2021, examined and compared effectiveness, safety and acceptability of medical abortion up to 10 weeks gestation before and after the widespread implementation of the no-test EMA. This large study found that a no-test EMA was not inferior to the traditional pathway. Moreover, there were many advantages. Waiting times and the gestation at which abortion occurred were reduced. They also reported high patient acceptability and satisfaction with the new service model. There was no evidence to suggest a worse outcome failure rate, hemorrhage, need for surgery, or failure to detect ectopic pregnancy. Although the overall results of no-test EMAs have been positive, there are still some concerns over safeguarding of vulnerable patients. In 2018, the CQC identified telemedicine as unsatisfactory in its approach to safeguarding. Bertini 2021 argued that just because a service is efficient and medically safe, it does not take into consideration the needs of emotional support. The decision to have an abortion can be a difficult one for many people. Coupled with the complexity of fear and uncertainty of the future in a global pandemic, this can be even more challenging. She argues that a rushed decision driven by anxiety and loneliness is not always the best decision. Face-to-face interaction often allows a healthcare professional to perceive this and support the patient through a clear decision-making process. The research clearly supports that vulnerable women would benefit from easier access to EMAs. However, those with complex social factors, as documented in 2010 NICE guidelines, need extra support due to their circumstances, such as problems with alcohol or drugs or due to domestic violence. The stressful environment characterised by social isolation and feelings of loss of control have also contributed to an increased risk of domestic violence. The social and physical distancing strategies used to mitigate the spread of infection can also increase domestic violence by increasing proximity to the violent individuals and decrease opportunities spent away from access support systems. NICE guidance emphasises the importance of in-person appointments with a healthcare professional to provide an opportunity to disclose difficult circumstances to a third person. NICE also suggests offering longer appointment times to give the right support and help. One of the criticisms of the Aiken study was that there was not a very good follow-up service following the EMA. Implementing a robust follow-up, coupled with the option of pre-appointment counselling and the offer to be able to attend clinic in person, should go further in improving the service for vulnerable patients. Although the new guidelines legally allowed for the fully remote service, not all abortion services took advantage of this. The way in which the service I work for implemented a change was to make the initial face-to-face appointments a telephone consultation, therefore limiting the risk of infection of COVID-19. Patients are still required to attend an appointment for an ultrasound, consent form, and to take mifepristone. However, in the future, if we do move to a no-test EMA service, there would need to be a robust assessment process with an adequate follow-up. There would need to be a new format for consent forms, which would normally be completed in person, and further training for the team to adapt appropriately to maintain patient safety. Our nursing team has always been accustomed to face-to-face encounters. The transition to telemedicine during a global pandemic presents both personal and professional challenges. Prioritising safety when assessing and responding to vulnerable patients is of paramount importance. Jack et al. 2021 suggests using a modified ADAPT-ITT framework. The ADAPT-ITT framework can be used to guide the novel identification and adaptation of evidence-informed guidance. They found that use of this framework fills a gap in available guidance, specifically for domestic violence recognition and response via telemedicine. Further to this, simple steps such as asking a patient if they are on their own during a consultation, and also making sure they are not on hands-free so that a patient can speak freely to verbalise any concerns they may have without anyone else present. Communication will also be key. We as a team will be required to have advanced communication skills to compensate to the lack of visual cues. One study suggests the use of the teach-back technique. This is a way of ensuring that medical information is explained clearly and then reiterated back to them as a way of confirming that a patient has understood the information correctly. It would also help ascertain if a patient has capacity to consent. It remains necessary for the nursing team delivering care remotely to adhere to fundamental principles, namely the skills needed to provide effective, evidence-based care that serves the patient's needs, so that proper valid consent is obtained and that patient safety remains paramount. We as a team have adapted quickly and effectively to the use of telemedicine in abortion care during the pandemic, and the benefits of it being done properly are obvious.